I would like to call upon a stage Dr. Rupali ma'am. For Dr. Rupali ma'am, she will proceed with a session of understanding anal physiology for better fistula surgical.
Good morning. Thank you to the organizing committee for this opportunity and also to include this topic, that is the anal physiology. So the anorectum, this area physiologically is mainly concerned with the normal defecation and also with the maintenance of the continence. Today we will focus mainly on the continence related physiology of the anorectum. So the two muscles which are surrounding the anal canal, that is the internal anal sphincter and the external anal sphincter, are mainly contributing to the continence around that area. In that, the internal anal sphincter is under the autonomic control. This is the continuation of the circular muscle, and this is contributing to the resting anal sphincter tone, and that's why it is contributing for the maintenance of the passive continence. Then the external anal sphincter, which is around the anal canal, this is a striated muscle and supplied voluntarily by the pudendal nerve, and that is responsible for maintaining the squeeze pressures around the anal canal, and that's why it maintains the active continence. To learn these function in detail, we have got a new procedure, that is the anal manometry. This helps us to understand the pressures around that area as well as the coordination around that area very nicely. So this system, basically it has a catheter, solid state and a liquid state catheter. Either 16, 24 or 36 channel catheter can be used. Majority system has 24 channel and the liquid system available into the India. It has a display software and it also has inbuilt analysis software for it. So International Anorectal Physiology Working Group has okay. So we'll see the indication for doing the anorectal physiology into the fistula surgery. First is the incontinence score. If it is suggestive of impairment, then we can consider. Then the recurrent and complex fistulas, sphincter defect on imaging, and in the female patient with anterior fistula or prior vaginal delivery, or with, if there is a history of prior episiotomy. These are the some of the indication for anorectal manometry into the fistula surgery cases. Then this International Anorectal Physiology Working Group has devised a standard procedure protocol. After putting the catheter, a stabilization period of 3 minutes is given. After that, the resting anal tone is measured. This is measured for almost 60 seconds, and this resting anal tone is basically suggestive of internal anal sphincter tone. Followed by that, we take the 3 squeezes of 5 seconds and 30 second one endurance squeeze. The squeeze pressures, as we have seen, it is indicative of the external anal sphincter tone. This is then followed by the cuff reflex. This is basically increase in the intra-abdominal tone will increases the anal pressure. This is a sacral reflex, protective reflex, reflex for the continence. Then this is followed by the push maneuvers or the evacuation maneuver, which is done for the 15 seconds. Here we ask the patient to simulate the normal evacuation process. This is then followed by the measurement of the rectoanal inhibitory reflex. This is a local reflex where we, after the distension of the rectum, there is relaxation of the resting tone. Then we do the rectal distension test to know about the rectal sensations, and at the end we do the balloon expulsion test. Then the software will analyze the reports and will get the information in such way. Then according to the London classification, which take into the consideration the 4 parameters, that is the anal tone, the contractility, rare reflex, then how is the coordination between the muscle and how is the rectal sensation, and we can devise the conclusion accordingly. And depending upon the conclusion, if it is suggestive of dyssynergy or incontinence, we can go forward for the biofeedback therapy. So like this is basically a reinforcement technique using the operant conditioning. So here the stimulus which I usually use is the visual stimulus. This kind of software is there. This will help us to give the biofeedback therapy. So now we'll come to the interesting case scenarios. I'll just show you the few cases. Okay. 32-year male patient with diagnosed complex fistula in ano. He's planned for the surgery. He came for the pre-operative anal manometry. So we'll just run through the procedure. This is the resting pressure. These are the 3 squeezes. If I'm not okay, I'll ask them to do more squeezes. Long squeeze, the cuff reflex, then the push maneuver, then the rear reflex, rectal distension test, and at the end we'll do the balloon expulsion test. So after doing this test, the findings which I got, the significant finding, the tone was okay, resting and the squeeze pressures was okay, but here the significant finding was finding the dyssynergia. There was miscoordination between the rectum and the anal. So as the tone was normal, so this patient can definitely go for any kind of surgery for the fistula according to the convenience. But as he is having dyssynergia, we can definitely ask for the biofeedback pre or post-operative. Then the next case, this is she is a 56-year-old female patient. She came for the fistula surgery, anterior fistula surgery. She had a prior history of sling procedure for urinary incontinence following vaginal delivery. And surprisingly, she didn't had any history of perianal surgery, and at present she is not having any clinical incontinence. We'll just run through her manometry. So this first is the resting pressure tone. Then these are the squeezes. You can note there are no any changes in the pressure. It is just green. Then the long endurance squeeze, cuff reflex, push. Then we will do the rear balloon distension. At the end, there will be balloon expulsion test. So here the significant finding which like according to the people sitting here, this patient is having anal hypotension with hypocontractility, means both her internal as well as external are compromised here. So this patient should be going for sphincter preserving surgeries. And noting this value, documenting this value pre-operative will definitely have a medico-legal significance post-operative. She was not having any continence pre-operative, so this will carry a medico-legal significance also. Now the third case, this is a 28-old had iatrogenic rectovaginal fistula following a repair of complex fistula in ano. She had surgery for rectovaginal fistula also, but now she was having the pelvic pain syndrome. So we'll just see her manometry. This is her resting tone, which looks good, but these are the squeezes, which are very weak. Then the long squeeze, there is also no changes. Cuff reflex. Then these are her push, they are also very weak. Then the rectoanal rear reflex is taken, and the rectal sensation and the balloon expulsion test was done. So the conclusion, like here, her resting tone was normal, means she was having anal normotension, but her contractility was poor, means her internal anal sphincter was normal, but the external anal sphincter was compromised. And as her external anal sphincter was compromised, she was overusing the glutes, leading to the pain in the pelvic area. So that was her main cause. So we gave her 6 to 7 cycles of biofeedback to improve the strength of the external anal sphincter, and she was nicely relieved of this pelvic pain syndrome. So the conclusion I would like to give is not only the anatomy, I think physiology should also start mattering as it being shown. So knowing physiology will definitely help to change the surgical plan, and also the post-operative mild incontinence or dyssynergia, if it is there, can nicely be treated with biofeedback for the better quality of life.
Thank you very much, Rupali. I think most of us have forgotten about the physiology, but your lecture has put us back on track, and we will make use of that. Thank you so much.
Thank you.